We're Group 4A. We're now presenting the hand function evaluation model developed by Professor Cecilia Li Zhang. In this video, we will firstly introduce the reasons for Dr. Li Zhang to develop the model, the methodology in her research, the components of the model, as well as the clinical application. Finally, we will reflect on our clinical experience and our future OT role. Dr. Cecilia Li Zhang first developed the model in 1999 when she was studying PhD in COHK. She realized that it is difficult to validate her research work and to justify the effectiveness of treatment interventions without good theoretical models. That's why she started to develop her own model. The hand function evaluation model is specified for preschool-age children with Chinese culture, because Dr. Li Zhang found that there are cultural differences between the targets of pre-existing models and Chinese children, causing misfit. This is why the model stresses on evaluation using tasks matching with Chinese culture. Also, she found that different cultures and environment will give different skills to children. Like Chinese children will be relatively good at fine motor skills, while Western is good at crossing motor. So, own framework is needed for a study. 120 kindergarten children participated. 4 kindergartens were randomly selected from 4 regions of Hong Kong. 15 boys and 15 girls were selected from 3 grades, including K1, K2, and K3, using stratified sampling method in each school. Also, the research involved 16 children with hemiplegia from outpatient clinics in one hospital by convenient sampling. All the participants joined the 3 levels of assessments, which are the motivation, sensory motor components, and connection. HFEM is a model that guides OT assessment process on the hand function of local preschool-age children. Therefore, the evaluation is influenced by the cultural context and focuses on the child development regarding the motivation, connection, and sensory motor components. In HFEM, hand function is evaluated in 3 levels, namely sensory motor components, developmental progress, and hand function performance. The first layer, sensory motor components, suggest OT to do assessments on the intrinsic factors that a child possesses. For example, the sensory motor performance, visual perceptual skills, cognitive functions, and psychosocial development. Sensory motor performance can be subdivided into group strength, dexterity, and stereognosis. Deficits in these areas result in sensory motor, visual perceptual, cognitive, or psychosocial dysfunction. Level 2, the developmental progression. This layer illustrates the use of standardized developmental assessments to identify children who are at risk for hand skill delays on fine motor movements. The assessments are criterion-referenced or norm-referenced. Children are asked to do some tasks that are related to their age. These assessments aim at facilitating referrals, planning of programs, and interventions. The third level is the hand function performance. Hand function, as defined as the abilities of the hand to cope with purposeful everyday activities, including self-care and academic skills, is considered as the primary outcome in this level. It suggests some outcome indicators that meet the pre-academic and self-care demand for preschool children in Hong Kong. 4 unilateral and bilateral tasks, such as buttoning, handwriting, chopsticks, and scissors, are used to evaluate on children hand function performance. The hand function evaluation model can be applied in different settings, namely physical settings like outpatient clinics, normal or integrated schools.